Okay, so we have another disease called adenomyosis, okay, and endometriosis. First we will talk about the endometriosis, and in next lecture I will tell you about the adenomyosis. So adenomyosis is the condition in which what happened, your endometrium will invade the myometrium of the uterus. Okay, so normally the endometrium should be inside the endometrium, okay, and it invade the myometrium, okay, that is called the adenomyosis. Adeno means, adeno is referring here the glands, okay, so glands only found in the endometrium. Meiosis means myometrium, so gland means myometrium inside the, sorry, endometrium inside the myometrium, okay. This is usually happen 40s to 50s year old women, okay. Endometriosis means endometrium outside of uterine endometrial mucosa, okay. Now outside it can be even ovary, even fallopian, don't confuse, okay. It can be in ovary, it can be in fallopian, meaning to say just outside of the uterine endometrial mucosa, okay. Okay, so here is the outline, definition, then theories of the pathogenesis. We will talk here 4 or 5 theories, and then the most acceptable theory is your retrograde menses, okay. This is the most acceptable theory, and we will talk in a detail about this, okay. Then we have symptom, diagnosis, complication, okay. The most important complication is your infertility, okay, very important. Then treatment. Definition: presence of the functioning endometrium inside other than uterine mucosa, okay. Most common site is your ovary, because this is near to the uterus, that's why it's very common, okay. Or it can be explained by the retrograde menstruation, I will tell you later. Other common site are pelvic, peritoneum, okay, Douglas, pouch of Douglas, I will tell you later. Next slide, your uterosacral ligament, then sigmoid colon, then appendix, then fallopian tube, okay. So here is the diagram showing the different type of region, okay. So look at this here, this is your posterior cul-de-sac, meaning to say pouch of Douglas, okay. Thus the lower posterior part of the uterus here, and then part of your rectum, or in between that here is a small space, that is called pouch of Douglas, okay. Then here is your sigmoid colon, okay. So here is endometrial tissue also. Look at the ovary, it can be here, then this is your urinary bladder, it can be here also, here, everywhere, okay, can be anywhere. So as I told you, retrograde menstruation, okay, explain the pathogenesis of your endometriosis, okay. So what happened in the normal menstruation when women have bleeding, okay. So that time what happened, the because of a unidirectional contraction of the myometrium, the blood and dead tissue comes out by expelled by the uterus, okay, to the vagina, okay. But what happened when that the contraction of the myometrium gets multidirectional or abnormal, okay. So what they will do, that time the blood and dead tissue will follow the wrong way, okay. Look at here, the blood is going all the way to fallopian tube, then it's coming out through the, it can come outside from here, because you remember that when ovulation occur, that time we called ostium, okay. It's a small hole, through that the ovum come inside the fallopian tube, okay. Then fimbric catch that, okay. So that means there is a hole from which the endometrial tissues can come outside, okay. So this explain very well that why is the ovary is the most common reason for the endometriosis to happen, okay. Then other has coelomic metaplasia. They said that peritoneal cell are multipotent, okay. They are multipotent. Multipotent means they can transfer or change into endometrial cell, because they have ability to change themselves to any kind of cell. Okay, that is the theory of coelomic metaplasia. Then lymphatic theory. So also the lymphatic theory says that the lymphatics of the uterus, okay, they also, I mean, the endometrial tissue can invade the lymphatics of the uterus, then go anywhere else in the body. Okay, this is the theory of lymphatic theory. Then direct implantation theory. Okay, not this is least important, so no need to, I just write because it is one by book. Okay, then vascular theory. Okay, so meaning to say that endometrial tissue can also follow the vasculature, then go anywhere in the body. Okay, so here is the pathogenesis and complication discuss in detail. Okay, so all the theory of pathogenesis here. Okay, so look at here. Okay, endometriosis, endometrial gland and stoma found outside of the uterus. Okay, they are outside of the uterus but they still functioning. Okay, that means they will react to the hormones. Okay, as we know that already, that in let me erase this. Okay, so I can explain better. Okay, as we know that already that when this is, suppose this is ovary. Okay, and this line is representing the ovulation or 14th day. Okay, before that we have a fully matured follicle. Okay, or after that we have corpus luteum, because after ovulation follicles become corpus luteum. So what happened that before the ovulation, this is the matured follicle here. As we know already that it secretes estrogen. Okay, and estrogen help to proliferate the endometrium. Okay, then after the ovulation, this follicle become corpus luteum. Okay, and this corpus luteum secrete the progesterone as well as estrogen, but remember that it secretes progesterone more than estrogen. Okay, so overall we will talk about the only progesterone here. Okay, and progesterone also help to proliferate the endometrium. Okay, that means that endometrium which is outside the uterus will also react with this, right? Because that is functioning also. Okay, okay, so first I will talk about this. So this is your 14th day ovulation here. Okay, before that I already told you that matured follicle will secrete the estrogen, so that's why graph is going up. Okay, this is your estrogen, and after the ovulation the corpus luteum will secrete progesterone, graph going up. Okay, and look at here. Okay, the estrogen which proliferate your endometrium, this is the lining of endometrium, this is endometrium. Okay, and look at here, progesterone also maintain the endometrium. Okay, and this is the region when women have menses after withdrawal of the progesterone here. Okay, that means if there is withdrawal of the progesterone in uterus, there is bleeding. Okay, that means it should be bleed even outside endometrium. Okay, okay, so let's come here again. So monthly progesterone withdrawal causes subsequent sloughing of the endometrial tissue. Okay, after the withdrawal we have bleeding. Okay, extrauterine endometrial tissue cannot evacuate implantation site. Okay, so what they do, they also bleed. Okay, when they bleed just outside the uterus, in anywhere there will be inflammation. If they bleed, there will be inflammation. Okay, inflammation irritate the surrounding tissue, and that will activate the nociceptor or pain receptor, will cause the pain. Okay, that's why this is the cyclic pain. Okay, because every cycle there is withdrawal of the progesterone. Okay, if there is withdrawal of the progesterone, there is bleeding even inside the uterus, outside the uterus, wherever is the endometrial tissue. Okay, and that will cause cyclic pain. Okay, now what will happen? Suppose in the first month we have injury outside. Okay, then what will happen? There will be repairing also. There will be again injury, again repair every month. Okay, there will be formation of fibrosis. There will be formation of scar tissue. Okay, if suppose endometrial tissue inside the ovary, what will happen? There will be formation of the scar inside the ovary. That will cause an ovulation. That will cause infertility. Okay, if suppose that endometrial tissue inside your fallopian tube, okay, will cause again and again injury every month, will cause the scar formation. Then will eventually the one day the fallopian tube totally obstructed. Okay, will cause the infertility again. Okay, now what will happen? The patient will come to you, they will say that I don't have menses, because there is no ovulation occurring. Okay, if there is no ovulation, there will be no progesterone secretion, no progesterone withdrawal. Okay, and there will be no bleeding. That's why amenorrhea will present with amenorrhea also. Okay, dyspareunia, pain during the sex. Why it will happen? Look at here. If suppose endometrial tissue are here, as we know already that when the couple sex, they do intercourse, that time the penis goes here in this site. Okay, it will compress these area. Okay, the penis will compress these area. It will compress these area. That means there will be pain also. Okay, there will be pain with the bowel movement. Again same pathology, same idea. If the endometrial tissue are here, if suppose stool coming from here to here in this direction, stool will compress this area. Okay, there will be again pain. Okay, then frequent urgency. If the endometrial tissue on the bladder, it will cause a abnormal contraction of the bowel. Okay, that will cause frequency and urgency. Pain with micturition, same pathology, same pathogenesis. Okay, so ectopic endometrial tissue compress adjacent nerve. Okay, ectopic endometrial tissue in rectouterine pouch. Okay, what will happen? Penetration of the penis into posterior vagina compress affected area in the rectouterine pouch. Okay, I told you already all the things. If feces moving will cause compression, they will cause pain. Okay, abnormal activation of the nerve causing bladder contraction, activation of the receptor when bladder wall contract. Okay, then I already talk about the pathogenesis of cyclic pain. Okay, scar formation will cause in nodule formation, then cystic formation, even accumulation of the inflammatory buildup in the scar tissue will cause cystic formation. Then I already talk about the infertility. Okay, symptom we already talked, dysmenorrhea. Okay, dysmenorrhea just mean that pain during menses. Okay, pelvic pain, dyspareunia, infertility symptom. Okay, how we will diagnose? By the laparoscopy. This is the picture that doctor is a doctor doing the laparoscopy here. Remember, laparoscopy is the gold standard for the endometriosis. Okay, but what we are going to see in the laparoscopy, we are going to see the gunshot lesion. Okay, it look like that someone shoot the gun. Okay, and the powder which is coming from the gun will cause the will spreading here, look like this. Okay, the powder gun appearance, look at here. And why it is the powder gun appearance here? Because of the recurrent hemorrhoids. Okay, because every time there will be, if every cycle after ovulation there is progesterone withdrawal, will cause the bleeding. Of course, will cause the bleeding even outside of the uterus in the endometrial tissue, which is present just outside the uterus. Okay, there will be bleeding also, will cause the hemorrhage again and again. Okay, so will look like the gunshot lesion here. Complication, chocolate cyst. Okay, chocolate cyst, why it is called chocolate? Because look at here, look like chocolate here. Okay, just similar to the chocolate. See, wait, look like chocolate, right? Yeah, that's why. So it can rupture even the, okay, cyst can rupture, will cause the infection into the peritoneal cavity, can cause the sepsis even, okay, and can cause PID possible. Okay, obstructive feature I already told you, or can obstruct even the your rectum, can obstruct the urethra, okay, can obstruct the fallopian tube. Okay, malignancy is rare, but the even malignancy is rare, but if there is malignancy, that is most common, maybe adenocarcinoma. And ovulation, told you about why there is an ovulation, hyperprolactinemia, then infertility. Okay, expectant management. Okay, expectant management means we are not going to give any treatment, we just closely monitoring the patient. Okay, so here the indication why, to which patient, to whom patient we need to go expectant treatment. Okay, if suppose endometriosis is very asymptomatic, there is no any abnormal finding on the laparoscopy, we no need to treat. Unmarried young woman, okay, because pregnancy will stop this condition. Okay, then your menopause. Okay, of course, because this is a hormonal thing, so if there is menopause, will cause stop the endometriosis. Okay, treatment, hormonal therapy. So combined oral contraceptive, these pills contain the estrogen and progesterone. Okay, of course, if we will give estrogen, progesterone from outside, they will inhibit the release of LH and FSH. Okay, because of the negative feedback. Okay, because GnRH will stimulate LH and FSH. Okay, they release estrogen and progesterone. Okay, if we are giving estrogen, progesterone from outside, they will cause negative feedback. Okay, decrease, then if it is decreased, this is also decreased. Progesterone pills, same function. IUD, intrauterine device, we can also give. Danazol, this is androgen receptor antagonist. So of course, we are just going to suppress the female hormone, because we have male hormone and they are antagonistic to each other. Gestatrione and GnRH analog. Maybe you are thinking how the GnRH analog will suppress. Yeah, it will suppress, because normally GnRH in the pituitary secrete the GnRH in pulsatile fashion. Okay, intermittent fashion or pulsatile, we can. But if you are going to continue give the GnRH, of course it will inhibit the FSH and LH. Okay, then also we have surgery, definitive hysterectomy. In hysterectomy, what we do, we take the uterus out, we take the ovary outside, we take the fallopian outside. 3. Okay, and usually is done in the people, if female is very serious. So if it is not, it's not usually done. Okay, the most of the patient will recover by the hormonal treatment or expectant treatment. Then laparoscopy also, cauterization and laser operation. By the laser, we just burn the lesion, then take out. Okay, cauterization also, the we take out putting some. Okay. Thank you.